So before we go to metastatic, any other, in the salvage setting, whether it be surgery or radiation, any other things we're interested and excited about, what we're doing in practice? Obviously these patients become metastatic and then they kind of end up with the medical oncologist, but any other things that the urologists are thinking about in the salvage setting?
I mean, for me, it's stuff that you're about to talk about, which is like, traditionally, if we go way, way back to like say the Messing study, way, way back, and someone had like lymph node positivity or something after surgery, it was like lifelong ADT, right? And then we started going towards like, well, maybe we'll do, some short course of ADT, maybe we'll think about how we might radiate that person. Now we have PET PSMA to show us things. And in the salvage setting, I think we're thinking more and more about what's the duration of systemic therapy that goes with salvage protocols. Do they, particularly when we salvage the pelvis, and there's even debate about low volume metastatic disease, do we even need any? Do we do what we'll call a doublet now, but a ARPI plus ADT? There's some, we were kind of mentioning one of the NRG trials that came out at Astro, Dr. Spratt presented, where it was a phase 2, but they were looking at apalutamide monotherapy, as for short course.
We just talked about this before this meeting here today. Right?
Yeah, and some people think from the EMBARK data with high risk BCR that maybe monotherapy might be more tolerable, less hot flashes and things like this. Or if you think about the studies, Dr. Nguyen's did a study in the salvage setting with radiation where they looked at maybe doublet for a shorter period of time is better than longer period of time. And we have data for a lot of men that are in the same age group that have hormone sensitive disease, that quality of life with a doublet, particularly like Avi or darolutamide, looks no worse than just the ADT alone. So I think, to me, that's like kind of like where the action is. I think where we are surgically, where the action is better selection of, if we're going to do focal therapy, how can we even improve even more on robotic prostatectomy to have earlier return of continence? A lot of us are doing different types of, Retz sparing, fascial sparing, better tissue handling. The new robots that are coming out are giving us ideas of force metrics when we do things, but that discussion is sort of in the weeds, but it's the same way that a radiation oncologist would think about tweaking their craft. If you're going to get radiation, are you going to use a flame protocol to boost lesions to these MRI areas? You might have seen the 10-year outcomes data just came out showing improvement. And it's like, really, how can we use, I would say, overarching, less systemic therapy, maybe more intense for shorter? How do we leverage the tools we have right now to get better outcomes? And I think that's what we live in the localized setting.
Yeah, I mean, we think about that in the metastatic settings too. You're maximizing quality of life. We know different things are important for different patients. So let's move on to more advanced cases, metastatic cases. Let's say we have a patient who, we find M1b disease, a bone lesion. What, testing are you guys doing to work those patients up? We talked about PSMA PET imaging. Any other testing, generation sequencing?
In the community, I've been doing sequencing routinely for all M1b disease. I think it has value. It predicts, there are some mutations, AR mutation will predict a response, whether ADT and ARPI may have a short-lived circumstance. But I think there's some value. It's still somewhat limited, and the reason why is because we're still looking for biomarkers that are really truly helpful in the setting of a treatment prediction and response. However, I've been using that as well as germline-based testing. There's obviously BRCA-based mutations or things that are sensitive to PARP inhibitor that will direct treatment. However, the sequencing is now really going to dictate a customized approach to the patient's care, particularly if you're looking at sequencing of long-term care for the patient and making sure that there's efficacy for the treatments that you're inserting at different timeframes. Not to mention customizing, let's say a patient comes in, you're talking about ARPI doublets, and patients are really, against a certain side effect or there's an issue in their lifestyle that may kind of come to play. The testing may help kind of tell you if this is going to be more effective versus less effective in that setting.
Yeah, I completely agree. I think in my practice, early on, a number of years ago, would kind of table the sequencing conversation to a later date And that's just come more and more into the forefront of our earlier conversations with patients. You know, there's so much to talk about in a patient if they present with de novo metastatic disease. Some of these patients might not have seen a doctor for many years and may not want chemotherapy or not really be interested in some intensive treatments. And so you kind of have to slow play the conversation to ease them into the diagnosis and the different treatments. And part of that is germline testing, part of that is molecular sequencing. And as we get more and more information, data now using PARPs in the very frontline setting in BRCA mutated patients, I think it's just really paramount to try and get that information as soon as you can.
I just want to jump in, talk about sequencing, and I'm guilty of this. I haven't jumped on that train early enough, but do we have to wait for medical oncologists to see a patient before we start ordering these tests? And I think that I'm becoming more comfortable to offer Tempus to patients, and even as a urologic oncologist when disease is high risk but localized. And I just want to hear Dr. Ross and Dr. Patel. I mean, a great point. I know you guys order this routinely, this is a routine thing, but I think there's still a lot of urologists and uro-oncologists out there. I think we're still shy of putting those orders in and ordering it ourselves. Just want to hear some comments.
No, first.
Yeah, I haven't actually ordered a lot of next generation sequencing in my localized patients.
But what about
Now they're starting to advance. Well, for sort of risk factor assessment and genomic assessment for the patient and their family, yes. Then I'm using that a lot more. But in the discussion of assessing their genomics for treatment and then treatment sequencing, I have not been on that.
Yeah, we're going to have it available at our institution, so you can just order it for
Yeah,
EMR, both germline and next generation. So you can order it if you.
And that's a huge thing. I mean, when you think about sort of, so there's a lot of things going on in the behavioral change and how the patients and the providers face this. Like you were mentioning, there's a lot for the patient to kind of absorb when they have newly diagnosed metastatic disease, or for us, even when they have high-risk disease. One nice thing is there's been so much mainstream knowledge about the understanding at the molecular level of disease that the patients don't get caught off guard when you say, we want to figure out what drove your tumor, what caused this, why you and not the other guy, you know? And so I think the resistance there is kind of low. When I was just several years ago, when I was seeing patients and I was thinking, okay, for high-risk disease, I want to do germline genetic testing to both help that guy understand if this was caused by something, he could talk to first degree relatives, be a sentinel for cascade testing and stuff. And if I want to do this, and I started doing it, my genetic counselors were their bandwidth was limited, you know. And the problem was when you do it yourself and it lives outside of your electronic medical record, it's hard to order. The studies are coming in, complicated studies coming in into outside of your EMR. You never know when they're going to appear. Right. You do multi-gene panels and there's more variants of unknown significance, right. You know, even a likely pathogenic variant. And as Dr. Patel said, it's not necessarily actionable for you as a surgeon. And they're adding in this extra layer of of stuff, and it may have implications for them and their family members if you miss a result. It made things hard. And so then I went to pathway 2, which is let you guys do it.
Yeah.
Or let a genetic counselor do it. And we have more recently been able to order exactly like you said, NGS and next generation sequencing from our EMR and get the results back to our EMR.
Yep.
And that has decreased a big barrier. The gene sequencing companies are trying to help as well. They'll say, look, do you want mobile phlebotomy to go out and draw their blood somewhere? Do you want to get saliva somewhere? Do you want to do it? They're also trying to help informatically. You mentioned Tempus. Them and some other companies are doing things like maybe a round of RNA-seq to reduce the variants of unknown significance. You know, maybe assays. We'll talk about maybe CHIP later, but to reduce white blood cell proliferation that can give false positives. And since we went to we can order in our EMR, I've kind of launched the workup so I can have it there for my medical oncologist, and I'll send out the Tempus, for example, or I've launched the workup years before they'll ever need it, and it can be sitting there in their file because it's used for forever. The same way that Dr. Patel was talking about, or Dr. Miocinovic, Dr. Mia, I'll say, was talking about where you guys are often doing the Decipher or the Artera so that when they get to the RADOC, they can make the decision. It's sort of the same thing. We want to package them so once they get to your practices,
Definitely find that.
I don't have to.
Yeah, logistically, it's just you're gaining another 2 weeks on
Yeah.
on the circumstance by the time that they would come to see us in the office. There's a logistics involved, but you know, there's a lot of discussion now about escalating treatment in an earlier setting for first line. Do we give docetaxel in conjunction to do doublet? And so where I find kind of the help with the sequencing is that if there is a potential that the disease may be more refractory or there's a higher mutation burden, I'm more suggestive to the patient about dose escalation and becoming a little bit more aggressive.
Sure. Yeah. I used to wait, similar to what Dr. Wiele was saying, because we have approvals for PARP inhibitors in castrate-resistant patients. But it does change my management in terms of monitoring sometimes. If there's an RB1 and a TP53, I might be, wanting to get some, different imaging. There can be uncoupling with the PSA. So it's impacted how I manage patients. And of course, if they have HRR mutations or a BRCA, that's going to change my second line.
I think there's a couple critical points there. When we think about hormone-sensitive prostate cancer, it goes, even metastatic, it goes into different buckets. And what you guys are pointing out is there's a smaller bucket that's critically important of like aggressive variant prostate cancer. Yeah. And even that has some different flavors. And the first question is, who do you want to get chemo into, And these guys, when we had older tools, were like the people that have Ki-67s that are like 30% or something, or maybe under histology, there's like, it's not small cell, but there's a lot of neuroendocrine features and high grade. As you mentioned, they're low PSA producers, and you're just smelling, this is a very proliferative cancer. I'm going to think about something that's going to attack that more. Maybe I want to do chemo. And now in the modern era, I was mentioning some of the Stampede data, Dr. Tard and their group published in Cell recently, of all things, a paper looking at on the Decipher platform, if they have P10 loss and a Decipher that's very high, above 0.8, that those people are having the best response to docetaxel, even indiscriminate of like their disease volume. And then similarly, and this will be controversial, we can talk about it, but if I was a patient, my age, young man, metastatic prostate cancer, and I found this, I had an RB loss and maybe a P10 loss, and you saw these neuroendocrine features, I might even think about give me docetaxel, maybe even think about like a platinum or something, because I know that those people are going to account for most of the deaths. And you were talking about sequencing before. There's a lot of data with the PSA that says maybe I can start therapy and see how you respond by your first PSA nadir in 3 months. As you go less than 0.2 or whatnot. For this small bucket of aggressive variant prostate cancer, that may be later than you want. It sounds ridiculous, but for you guys that see this and breathe this, it's not,
Yeah,
so.